Okay. Well, I can see myself on the screen, so I'm hoping you can hear me. If not, just send me a message in the chat and I will stop. Okay, so I apologize for not being able to be there in person. I think I'm one of many who are acquiring COVID, and so I am sort of partway into recovery. And so for this, your safety, I have chosen to do this virtually. So okay, so as James has said, I'm going to be talking about regular cannabis use in patients with eating disorders and looking at trends over legalization. And just to give a quick outline, so I'm going to talk about the idea itself. I'm going to give a little background of the literature, and then I'm going to share our findings and the implications. And before I start, I would like to acknowledge the other people who have worked on this project, particularly Kyla Belisario, who is responsible for all the data analysis that you were about to see. And this study was done in coordination, a group. We do work between our labs, the Eating Disorder Lab and PBCAR. And this particular study was done with support from a Living Labs grant through PBCAR. And none of the authors have any conflict of interest to declare. So in terms of the idea, in our eating disorder clinic, which opened in 2001, we've been asking patients about frequency of cannabis use and assess for cannabis use disorder since we opened. And sometime in the last decade, we noticed a change. So we noticed that it seemed that there were higher numbers of patients using cannabis at higher frequency. We were having an increased number of patients in cannabis withdrawal who were saying that they required cannabis in order to eat, which is problematic in eating disorders treatment. And then we had patients who were reporting cannabis use for the management of anxiety, sleep, appetite. So we just had a lot more people coming in, it seemed like, who were using cannabis and having negative effects of cannabis. So in terms of the literature, so I know this is an audience that is well versed in this, but I'm going to just put the context into place nonetheless. So in terms of, cannabis in Canada, the three main dates that I think are important for this study are the ones where legalization changed. So 2001, where the marijuana medical access regulations, and as you know, at that time, medical marijuana was highly restricted. There was a small list of people who had eligible chronic severe illnesses, and you had to apply to the federal government. And then in 2014, the marijuana for medical purposes regulation, the federal government no longer needed to authorize use. Instead, eligible healthcare professionals, who were mostly physicians, just had to endorse use, and virtually any healthcare condition was eligible. And we had federally licensed producers who supplied cannabis through mail order, and cannabis dispensaries, which were illegal, were proliferating at the time. And then in 2018, we had Bill C-45 and the Cannabis Act, which legalized recreational use. And in terms of perceptions of medical cannabis over this time frame, and particularly once medical cannabis was legalized, so with legalization, we know that cannabis became cheaper, more readily available, and the public just generally had decreased perceptions of harm. And in a large community sample in Canada, when we looked at the perceived benefits, or when they looked at the perceived benefits of cannabis being relief from stress, anxiety, or depression, 75% of non-users and 86% of users agreed that that was a benefit of cannabis, that the relief from stress, anxiety, or depression was a benefit that you could look to cannabis for. And when we look at the reasons given for medical cannabis use, Anxiety is one of the highest reasons, most common reasons given, and about 44 to 58% of people who are using what they are describing as medical cannabis report using it for anxiety, and about 30 to 50% report using it for depression. So I'd now like to talk about, sort of what I'm going to describe as the threshold of a problem, which is regular cannabis use. And in general, and again, I know that this is an audience that's very familiar with this, but in reviewing the risks of cannabis, frequency has been much easier to measure than quantity and type of cannabis. And in our program, we only measured frequency, so we were limited to that indicator. And regular or heavy cannabis use in mental health has been defined as at least weekly use. And when they look and compare daily users to weekly users, 19% of daily users and 17% of weekly users meet criteria for cannabis use disorder. So you can see that the threshold of weekly cannabis use and higher, you're ending up with a similar number of people who are going on to develop cannabis use disorder. And for a number of these, causation is still being clarified, but regular use is associated with numerous adverse outcomes in mental health. So psychosis, increased social anxiety, depression, suicide ideation and hospitalization, and of course, cannabis use disorder. And we're particularly interested in eating disorders on the effects of regular cannabis use in females. And the use in females is of interest because in eating disorder treatment settings, females outnumber males at a ratio of 10 to 1. And so with regular cannabis use, females have been shown to be more likely than males to experience symptoms of anxiety, depression, and psychological distress, to experience suicide ideation and hospitalization for suicide, to be more sensitive to the reinforcing properties of cannabis and therefore progress more quickly to developing cannabis use disorder, to have strong symptoms of withdrawal from cannabis use, and in particular to be more likely to experience stomach pain and nausea during withdrawal, which again is particularly relevant to our population. And then just to sort of recap the trends that we know were happening at the same time in the general population. So the 12-month prevalence of cannabis use during changing medical legalization. So it increased from 9.4% in 2004 to 18.4% in 2017, with the biggest increase occurring after 2011. And then the 3 months prevalence of cannabis use with legalization of recreational cannabis use increased from 14.9 in 2018 to 16.8 in 2019. So we're seeing, as have been mentioned by previous speakers, sort of an uptick in sort of at the very least infrequent use. But interestingly, daily or almost daily use has remained stable between the years of 2004 and 2019, which is the same time period where we looked at our data, and it's remained stable at around 6% in the general population. Now, in terms of trends in the mental health population, there's actually really quite little research that's been done. And in fact, we could only find one study of general psychiatric inpatients where their pre-admission previous 30-day cannabis use was looked at. And they did see a significant increase from 2007, where the previous 30-day cannabis use was 16.7%, to 2017, where that had increased to 25.9%. And the authors say that this perhaps indicates increased attempts at self-medication, because they note that this was happening during the time when medical cannabis was legalized. But they collected no measure of frequency of use, nor did they examine any change in trend of use over that time. They were just able to say that it had in fact increased over that time period. So looking at eating disorders and cannabis use. So just generally to sort of understand a little bit about, eating disorders, the use of cannabis within the eating disorder population. So the majority of patients with eating disorders do have comorbid psychiatric illnesses, and the most common are depression, anxiety, and substance use disorders. And cannabis is one of the most commonly used drugs after alcohol, tobacco, and caffeine. And both lifetime and current, so both 12-month and 3-month prevalence of cannabis use is higher in individuals with eating disorders than the general population. And rates of cannabis use are also higher in the eating disorder than general population, but not as high as you would see in populations with psychosis, for example, or depression. So it tends to be just sort of slightly higher than the general population. And there's greater prevalence of any and cannabis use disorder in patients who are reporting symptoms of both binge eating and purging. And that is in part because that population has been explained as being more impulsive, because binge eating and purging are both seen as impulsive type behaviors. So in comparison, for example, to restricting anorexics, who are individuals who are only restricting their food and are not engaging in any type of binging or purging behaviors. And so we have seen over history greater prevalence of both any and cannabis use in those patients who are engaging in binge eating and purging. And then eating disorders, and this is one of the main reasons for concern, eating disorders themselves are associated with higher risks of mortality, which is worsened by comorbid cannabis use disorder, with an adjusted hazard ratio of 4.55. In terms of eating disorders and cannabis expectancies, again, there's very little research on this, and we could only find one study on individuals who had eating disorder symptoms. And like people in the general population, people with eating disorders generally had positive expectancies for cannabis. So they believed that cannabis could help reduce body image preoccupation and fear of weight gain. And also the cannabis might help reduce fear of eating, dietary restriction, and compensatory behaviors. However, they also had some negative expectancies for cannabis, fearing that it might increase the risk of binge eating, and also not believing that it would help with feelings of loss of control related to binge eating. So it's a bit of a mixed bag in terms of expectancies. So in our current study, we looked at patients who were admitted to our outpatient clinic, and we looked at trends in regular use. So that's the weekly or more often over the time period between 2004 and 2020. And we used segmented regression to look at any significant change in slope of use over that time period. We also compared the cannabis use trends to trends in alcohol use and illicit substance use over the same time period. And we looked at whether particular eating disorder or perhaps comorbid diagnoses increase the odds of regular use, because, as I've mentioned, anxiety and depression are very common reasons people endorse for using medical marijuana, and those are also very common comorbid illnesses in patients with eating disorders. So we did want to see whether having those particular comorbid diagnoses might increase your odds of regular use. And we also wanted to see whether cannabis use disorder diagnoses would increase should regular use increase. So in terms of our findings, so I just want to give you just a little picture of the sample. So we had 843 patients, which represented close to about 80% of the sample who were, or just of the total number of patients who were coming into our clinic. And what we have is we have in the blue section over here are those patients who have some form of anorexia. So they either have restrictive anorexia, which is the people who are restricting their food intake, perhaps over-exercising, but not engaging in any binging or purging behaviors. Then we have the people with anorexia who engage in binging and purging. And we also have this other category, which is also called atypical anorexia, which are for people who are still in the either normal weight range or even overweight range, but who have experienced significant weight loss and have all the other symptoms that we look for with anorexia. And then the yellow group over here are the people who have bulimia nervosa and bulimia nervosa of low frequency or short duration, which is the other specified feeding and eating disorder, the OSFED diagnosis here. And then we also group them together with the folks who have purging disorder, who are not binging, but who are engaging in purging. And then the green section over here are the folks who have binge eating disorder and OSFED binge eating disorder, so which is people who have binge eating of either low frequency or shorter duration. The numbers are actually quite low. By far, the majority of patients here actually met criteria for binge eating disorder. And again, and just in terms of a quick description of the sample, I'm going to only highlight a couple of things. So one of the things I just want you to notice is that when you go across all of the diagnoses across the top here and you look at the age, almost all of them are in their late 20s. So that is the mean age of the patients coming into our program, with the exception of folks with binge eating disorder who are in their 40s. So they tend to be an older, more middle-aged sample. And then when you look at gender, I also just want to highlight again that we are definitely seeing, a high number of females coming into our program, with the, lowest number being for folks with binge eating disorder, 91%, and then going up to as high as like 96%. And we did also have significant differences around ethnicity. We don't have any particular reason for understanding that or for predicting that. So I just note that it is, there are significant differences. And then if we look at cannabis use, and again, this sort of highlights why it is important to distinguish between any cannabis use and regular cannabis use. Because if you look at the any cannabis use, we actually see kind of similar outcomes to what was reported in the earlier literature, where folks who are engaging in the combination of binging and purging, so the folks with anorexia who are doing binging and purging, and the folks with bulimia who do binging and purging by definition, they are actually engaging in some cannabis use at a higher, significantly higher frequency than, for example, the folks with anorexia who are atypical anorexia, and also compared to the folks with binge eating disorder. And when we look at regular use, in this case, you can see that really the highest use is only amongst patients with anorexia who are binging and purging, and they have significantly greater frequency of regular cannabis use than folks with bulimia, than the folks who have purging disorder, and the folks who have binge eating disorder. And just so that just gives you sort of a picture across the entire sample, not really considering any trends over time, but just sort of saying that we are kind of seeing that, yes, in terms of prevalence, we do see a higher tendency for folks who are both binging and purging to be engaging in cannabis use. And regular cannabis use, we're really seeing sort of the folks with anorexia who binge and purge showing higher likelihood of regular cannabis use. And so in terms of trends, and I'm going to show you a graph, but I'll just give you the results first. So we did see a significant increase over time in regular cannabis use between 2004 and 2020. However, that doesn't really give a good sense of what happens, and the graph will, that I'm going to show you next, will really give you a much clearer picture. And in doing the segmented regression, we used 6-month time intervals, and so we had 32 time points, with mean observations per bin being approximately 26 observations, plus or minus 8.56. And we did find a significant breakpoint using segmented regression in January of 2014. And what we saw was that, in fact, regular use was trending down from 2004 to 2014. And regular use was close to the population average of about 6% by 2013. But then there's a rapid increase from 2014 on, reaching a high of 23% endorsing regular use by 2020. And over that same time frame, there was no change in the frequency for alcohol or illicit substance use. So just showing you the graph then. This is regular cannabis use across the entire sample of patients with eating disorders. And as you can see, there is a steady downward trend until right before 2014. And at 2014, we see a dramatic increase going higher than it's really ever been before, up to about an average of about 23%. And over the same time frame, in terms of looking at the percent of patients who are endorsing alcohol use or illicit substance use, you see no change in slope over that time frame. And by the way, even though I haven't presented it, if I go back to this particular graph, this graph is also very similar when we looked at any cannabis use in eating disorder patients. We see a decrease and then a rapid increase after 2014. So then sort of the question was, what are we seeing within the particular eating disorder diagnostic groups? And what we are seeing is that from pre to post 2014, so comparing, pre and post the breakpoint, we see a significant increase in regular cannabis use in that blue group, so the global anorexia group. And we see that their overall increase in regular use has actually doubled, from 10% to 21.9%. And in the global binge eating disorder group, we actually see an even more dramatic increase, going from 1.37% to 9.74%. And interestingly, because, folks with bulimia have historically been the ones that have been seen as, more likely to engage in impulsive behaviors like cannabis use, we see no significant increase in the global bulimia group, so that yellow group, with the regular cannabis use changing from 9.33 to 11.38, which was not significant. And when we look at odds ratios controlling for time and age, what we see is that it helps sort of explain, even though we're seeing these increases in the global anorexia and the global binge eating disorder group, it helps sort of explain what's going on in those groups. So for the global binge eating disorder group, the odds of regular cannabis use were actually significantly lower prior to 2014 compared to all the other eating disorder diagnoses. So what that means is that even though we're seeing a significant increase, we're starting from a place that is significantly lower than all the other eating disorder diagnostic groups. And also, regular cannabis use increased significantly although it increased significantly after 2014, regular cannabis use in the global binge eating disorder group is now actually more consistent with the other eating disorder groups prior to 2014. And when we look at the global anorexia group, which is really of great concern because the folks with anorexia are also the ones who are at the highest medical risk. So what we see is the odds of regular cannabis use is significantly higher for the global anorexia group after 2014, and specifically in patients with anorexia binge purge type. So when we look at the actual change in use, the use actually tripled in patients with restricting anorexia. So those are the patients who've historically been seen as not impulsive, not likely to engage in sort of substances, and their use has tripled since 2014, and it's doubled in the folks with the anorexia with binge purge. And in comparison, however, it's remained stable in the atypical anorexic group. So it's really focused more on the underweight population here. And then looking at the odds ratios in relative to either substance use or comorbid diagnoses. So there were significantly increased odds of regular cannabis use across the entire time, so both pre and post 2014, with really relatively little change if patients were reporting other drug use. And there were also significantly increased odds of regular cannabis use after 2014 in patients who reported any alcohol use. There were lower odds if they were diagnosed with social anxiety after 2014. And there were no increased odds for comorbid depression or anxiety post 2014. So that increase that we see after the legalization of medical cannabis does not seem to be related to comorbid depression or anxiety. Interestingly, there were significantly increased odds of regular cannabis use before 2014 if you had a diagnosis of depression. So it seems like something has kind of drowned that effect out after 2014. And we see also a significantly higher percent of patients who are being diagnosed with cannabis use disorder after 2014. So in sum, regular cannabis use increased between 2004 and 2020, with a breakpoint in 2014, coinciding with the liberalizing of medical cannabis legislation. And regular cannabis use increased well above population rates of 6% to close to 23% by 2020, so prior to the pandemic, with significant changes in patients with anorexia diagnoses and with binge eating disorder diagnoses post 2014. And compared with other eating disorder diagnoses, patients with anorexia binge purge type have increased odds of regular use, but not patients with bulimia or patients with binge eating disorder. So that general characterizing of them as impulsive doesn't seem to be relevant in this situation. And patients with other substance use have the highest odds of regular cannabis use, and alcohol use is also associated with regular cannabis use. Comorbid psychiatric diagnoses did not increase the odds of regular cannabis use, both sort of particularly after 2014, and increased regular cannabis use was also associated with increased cannabis use disorders. And then given that I'm a clinician primarily, so the implications for us are that in eating disorder clinical populations, patients have increased regular use and possibly in an attempt to self-medicate, because it seems like the timing makes it seem more likely it's not recreational, but instead self-medication. And that was our impression in terms of the reasons patients were giving us for why they were using at the levels they were. We didn't actually measure people's reasons, so this is mostly speculation and our clinical impressions. We also think it's important to disseminate the actual findings regarding the efficacy of cannabis in treating mental health conditions to patients with eating disorders, because there isn't good support for its use with certainly with eating disorders, and nor with anxiety or depression. And patients with cannabis use disorder and eating disorders should be informed of the increased mortality risk. And patients with regular cannabis use will likely need support to reduce use. And also patients experiencing withdrawal, particularly stomach pain and nausea, may need to address cannabis use before receiving eating disorder treatment. Thank you. I'm not sure if people have questions or what the next step will be.
Hi, Michelle. These are fascinating questions, fascinating data. I'm wondering if you could speak as a clinician as to whether you see certain patterns of use or sort of functional relationships between cannabis use and eating disorder symptoms in terms of avoidance behavior or other kind of interrelationships between the two, rather than simply kind of co-occurring behaviors.
I do think that, like there is a connection for some patients between the use of cannabis and then a vulnerability to binge eating. So, like that relationship, I think that we would have predicted, we do in fact see in a number of cases. But I think what's interesting is, and what was unexpected, is that the increase is happening in primarily in patients with anorexia. I know it happened in binge eating disorder patients, but I'm not sure that that isn't just sort of that population kind of well, I suppose like in terms of the sort of catching up with their other eating disorder peers, but also because they're that more middle-aged group, just with the changing perceptions around cannabis use with legalization, that they were more likely to kind of get on board, as in part because it didn't seem as problematic to be using cannabis. For the folks with anorexia, though, it has been my impression in just the things that patients have said that they begin using cannabis because they hope it will help them manage anxiety. And there's a tremendous amount of anxiety associated with living with anorexia, sort of independent of a comorbid diagnosis. It's just living with the constant distress around what you're eating, what you're going to be eating, what you have eaten, what's going on with your weight. Like there's just a lot of anxiety there. And my impression in talking to some of the patients is that they get started using cannabis and then they increase their dosage thinking it's going to help. And then what happens is they end up in a situation where I actually am thinking it's making their anxiety worse, because they certainly seem like they are high levels of anxiety and distress, but also now they're beginning to experience withdrawal. And so I would say that I'm thinking that if we do a next step and we are able to look at what people's reasons are for using cannabis, particularly at the higher levels, that their own experience of anxiety directly connected to their eating disorder, potentially also connected to their comorbid illnesses, but certainly directly connected to their eating disorder, would be one of the reasons they might give for why they are smoking at these higher or using at this higher level.
Because I think of anorexia as being very much a condition of high anxiety, high over control, and cannabis often induces a sense of loss of control and can induce panic in some cases. So the high rates are on their face a little bit paradoxical, but it does make sense that if there's a ostensible use to manage anxiety, that might be a kind of path into use that then escalates, even if it ultimately exacerbates the symptoms. Thank you.
Yeah, yeah, absolutely. And I do think it's interesting because I'm not surprised that, in a way, that the folks with anorexia who binge and purge, because they're already experiencing some loss of control around eating. So I'm less surprised that their use has increased. But it was the tripling in the folks with restricting anorexia that was really surprising to me. And what it really made me think is that really the public in general does not, just the way in which medical cannabis was legalized, we didn't take the usual steps in legalizing a medication in looking at, efficacy or safety. And instead, there's really this kind of widespread belief in its usefulness for many, many things. And I think that the legalization of it has, and particularly given that the public does associate it with a relief from anxiety and mood, I think it sort of legitimized its use in this clinical population. And so it would be very interesting to see whether, in other clinical populations, whether they have experienced any kind of similar increase in that regular cannabis use.
Son. Hi, I'm Elian Ratcliffe. I'm a pediatric gastroenterologist here at McMaster. So I've been interested in cannabis and GI effects. So I'm really fascinated, as you described, there's this whole overlap with all these GI symptoms. And we've done some systematic review work looking at things about cannabis or cannabinoid products and appetite and nausea and vomiting and gut motility. So just it'd be interesting going forward to maybe try and tease that out a bit, because I imagine that's also a big confounding variable if they're using the cannabis and it's affecting their appetite or making them feel nauseous.
Yeah, it's actually quite interesting. I had wondered whether um, if they began to realize that it was preventing them from eating, whether that could be incentive to use high levels of cannabis. Um, but I'm also aware patients don't seem to really realize that that is a potential withdrawal effect of cannabis. And one of the things that's been quite interesting is we've had a number of people referred to us with significant weight loss who themselves are denying having an eating disorder, but the family physician is trying to figure out what's going on because they have definitely experienced significant weight loss, but they're claiming to have significant stomach pain and nausea. And when they come to us, we realize like they don't meet criteria for an eating disorder, but they are using cannabis at high levels. And so it's turning out to be a differential diagnosis that we are having to make more and more often, something that honestly, because I've been in this particular clinic since 2001, and we really never saw until the last decade or so.